Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, we kind of start we're going to do a little mini series.
What a journey today already.
Yeah. So we're at Parker University here in Dallas, Texas for the World Neurodynamics Congress. And so we just finished our morning session. So we heard from Michael Shacklock, obviously. Bill Morgan was nice enough to do an intro for us, Dr. Michael Leahy, and then, of course, Dr. Antonio Stecco. And so our goal with these little mini series throughout this weekend is going to be to highlight some of the things that is integration at its finest, right? So, Antonio, we tasked you with talking about the fascial system's relation to not only peripheral nerves, but central nervous system as well. And so, it was a great kind of mixing and matching, talking about neurodynamics, talking about your theories as far as what can cause some of the peripheral nerve entrapments. I know, Michael, you're a pioneer in neurodynamics, and so you had a couple questions actually, or maybe some different thoughts that Antonio said. So,
yeah, actually, overall, I felt we were on the same subject, speaking in quite similar ways, but different layers. Mm-hmm. And I sort of felt like Antonio's layers was deep into the nerve and connections, but the way I've presented neurodynamics is a bit more outside that, thinking of pressure systems and movement and things like that. So I kind of felt we were on the same subject, but just different layers. Mm-hmm. But one of the questions I was interested in, I've seen some of your research about paraneural tissues and area, and I've been using the word mesoneurium and epineurium, and I was just curious to see what your interpretation would be for those things.
Well, we try to, use the same terminology for tendon, for muscle, and for nerves. So whatever is much internal and divide a minor part, like a collagen, like a bundle, collagen fiber bundle of muscle, we call endo. So endoneurium, endotendon, endomysium. Mm-hmm. Whatever surround a bundle of structure within like the element is a perimysium, perineurium, a peritenon, okay? And then there is on top of that, we call epimysium, epitenon, epineurium. And then there is the para, okay, or perineurium. The one is really on the top of it is like a paratenonium. So on side of the tendon, the compartment from that, perineurium that is go all around. Of course, like at the end of the muscle is basically a crural fascia, like a deep fascia. Okay, so we try to match what is in the literature and match what can be replicable and use the same terminology as possible.
Oh, good. Okay, so we use term mesoneurium. I'm thinking that would probably be a deeper layer of the paraneurium.
Well, it's possible because on top of the epineurium, you have multiple layers. The one that go around it's not just one layer go around the nerve. There's multiple layer between loose connective tissue, so that is easier to maybe to isolate one layer compared to the other, and so give you eventually another name to that.
Okay, and then further out would be the deep connective tissue. Is that deep fascia? Sorry.
Out of that, you have intermuscular septa, okay. Or deep fascia. Okay. Remember that the muscle can have also the third level perimysium can be primary, secondary, tertiary. Like the primary is the smallest one, and then secondary is a little bit thicker, and the third is thicker. So sometimes when you do a dissection, it's even difficult to see a border between a muscle and the other. It's not as clear as you see like in the textbook. Exactly. So sometimes it's like a kind of perimysium, a thick perimysium, almost intermuscular septa. Then, hold on and generate the compartment also for the nerve.
Okay, good.
And you guys, it's almost like you're working from two different ends of a continuum. Maybe you're a little bit more concerned about like how the nerves are moving through the fascia and the muscles. You're more concerned about the fascia and the densification and things like that. Where do you think the crossover is between those two things? In your line of work, Michael, where would you maybe have a place for fascial manipulation? And in fascial manipulation, where might you use a neurodynamic technique to help in a certain case?
Well, in my case, like all the like evaluation tests will be very important because, as we said, we can never exclude that a patient have a nerve entrapment. Okay, sometimes the symptoms are very minor. Okay, on and off. Okay, so you have to try to exacerbate the symptom or try to figure out if there is something wrong in your office to make clear diagnosis. So have a nice test of neurodynamics to prove a little bit symptom or prove that there's a disorder. You can make a clear diagnosis. You can understand where the symptom coming from. It can then apply maybe fascial manipulation to restore the environment where the nerve is located. So I really believe I'm now so confident in the material, but my colleagues are, and they take a lot of advantage to know the neurodynamic test.
Actually, that's really interesting because I sort of feel like there's a lot of discussion. We know there's a lot of discussion in the clinical world about fascia system being very extensive. It is. But neural system is also extensive. And so some statements will be you can't differentiate. And I think that's true for a lot of cases. But I think thinking clinically, as I said before, if you do a neurodynamic test, it's perfectly normal. It probably means that person doesn't necessarily have movement-related nerve pain, but it doesn't exclude other things. Right. And so I think one of the benefits of a neurodynamic test is actually paradoxically excluding nerve if it's perfectly okay. And as Antonio said, you can't really exclude a peripheral neuropathy because that's true that some are asymptomatic. We know that from the tests that have been done. And so what we might say is that could be a peripheral neuropathy, but it might not be symptomatic with a neurodynamic test. So there's probably subgroups or different types and different ways of testing for them. We need to know more information, but I think one of the strengths of neurodynamics is if you do a precise and adequate test and it's perfectly okay, well, at least that person for that test doesn't have movement-related nerve pain. They might have fascial compression or irritation, but I think that helps exclude the neurodynamics. That keeps us out of the dangerous area, which is if we can't differentiate between fascia and nerve, if we're saying it is a nerve, we're not excluding fascia. So it becomes confusing. So if we reduce it to the finest logic, hopefully we're accurate in saying at least we can exclude a movement-related nerve pain aspect with a neurodynamic test.
Or if there's 7 trillion nerves in a body, let's just say, in neurodynamics, we deal with more of the bigger nerves of the body. Is there a chance that maybe like with these smaller nerves that are involved with like fascia and things like that there could be little minor nerve entrapments within the fascia that are maybe getting missed with the bigger nerves in assessment potentially?
Well, technically, yes. Remember that if subject has hypermobility due to a very loose connective tissue, that will make it much harder, the evaluation. You will have a lot of false negative. Right. So that could be something that has to be taken in consideration when you assess any subject. So adults, Marfan, or just a hypermobility of a teenager, can make it harder for you. Of course, the minor, all the free nerve, most of the free nerve endings, the somatic one merge in the connective tissue. So basically, you can have a small irritation, in some movement, in some mechanical test. But of course, it's hard to define that. It's much easier to define a larger nerve entrapment where the manifestation is quite clear.
And one of the powers of, I think, the neurodynamic system is you have an exclusionary criteria, which is we know who's not a treatment for neurodynamics. Do we have the same thing with in the fascial manipulation technique where we can just rule out the fascia as being a problem, or is everybody kind of in the inclusionary criteria, I guess?
No, the palpation that we perform over specific spots in relation of the symptom of eventually tests that we also apply, it helps you to make a diagnosis right away. Because if you have a multiple areas that are stiff, okay, and maybe they recreate the symptom because you palpate some area, you recreate like a tingling, numbness. You know that area is not over the nerve, but it's nearby. It can generate a stiffness that will pull down there and will affect the nerve. So there is also a very important syndrome, the partial Turner syndrome. That is a particular syndrome where basically the nerve twists and flip and basically flare up like the epinephrine. It is a terminal manifestation with like a huge pain, lack of decrease of the tropicity of the muscle. And the patient will really lose, like most of the time, deltoid. They don't know where is the region of this problem because the entrapment, this twist of the nerve, occur in areas that are not typical area of entrapment. So what we have published is an hypothesis that the nerve is like a rope. It's rigid and not elastic. So if you entrap proximally, if you entrap distally, and you move, it can be at the center, the nerve will twist and then it will flare up the epinephrine. So this is to explain a lot of time the real entrapment can be in a healthy area, not critical area, but the entrapment proximal distal will make this area become like the manifestation of the problem. Okay, because the lack of gliding will occur in area that are not exactly the typical area that you maybe think about. Okay, so also at the level of the epitrochlea, of course that the nerve can click, can snap out, but maybe because entrap above and below, and so the pulley become the area of manifestation of the symptom, okay? Because there is lack of gliding proximal and distal to that area. So the nerve is not extensible as a tissue, so we have always to assess globally the nerve and don't be focusing just in the area of the symptom.
Well, I think that's a good kind of an overview of basically everything that we talk about, Brett, is that global manifestation, meaning we need to look globally with our patients in order to really get an idea of what's going on with the dysfunction locally. And so neurodynamics does very similar things, right? So we could be using a distal neurodynamic test to assess the proximal cervical spine. Just like in fascial manipulation, we may be assessing above and below or proximal and distal in an area to try to get dysfunction. I think that's a very commonality amongst even like active release technique and other things that we're talking about this weekend, is that the global system is very, very important.
Yeah, I've seen Dr. Leahy speak, yourself, and so forth, and I'm seeing more and more commonalities. I think the skill is figuring out the dominant mechanisms.
Yeah.
Exactly. Or like if we're using neurodynamic testing as a baseline, and we use fascial manipulation as a technique, and that were to improve our neurodynamic testing, then what would that tell you about that case if we were trying to pinpoint what the problem was?
Well, that's really big. Well, if you come down to the reductionist thing, if it works, do it again.
Right.
If it doesn't work, then you have to review the effectiveness, and you might change. And that can put you into different systems or do different techniques within the same system. But in the end, it's the audit. It's the reevaluation.
The portal of entry can be different, but you're probably going to...
And the rationale or the mechanisms, the structures, the fine parts probably are not so easy to determine.
Yeah. I just think neurodynamic testing can be such a great baseline for like an audit for a lot of things, even if you're not actually even using neurodynamics in the treatment sometimes.
Exactly. 100% agree. Well, I think a great start to the weekend, Brett. I think today is very manual therapy based, which is kind of nice, right? We're talking fascial manipulation, we're talking active release technique. We have neurodynamic spit in there too, which is great. And then Dr. Seaman, David Seaman, is going to talk about the things that we do on the internal to affect the external, which is really nice. And so that's kind of like the sum of our day one, which is really exciting. But thank you both for being a part of this, for being willing to share with our people here today, and for continuing to push the envelope with what's possible for musculoskeletal health, right?
Right.
Yeah, beautiful.
Thank you.
All right, guys, thanks for tuning into our little mini-series. Stay tuned for more. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.